Okay, thank you very much and welcome back for this afternoon session. In this afternoon session, we are going to see about clinical epidemiology. So by definition, clinical epidemiology is the science of human disease investigation with, which focuses on diagnosis, prognosis, and treatment. So simply, clinical epidemiology is a human disease science which deals with investigation of diagnostic procedures, investigation of the prognosis of any type of disease, and investigation of any therapeutic effect. So that is the definition for clinical epidemiology. So the generation of a reasonable question requires definition of patients, definition of intervention, definition of controls, and defining the outcomes, So the goal of the research in clinical epidemiology is to minimize error, to ensure adequate sample size, to measure the input and output variables appropriately, and consider external and internal validities, and limit the bias, and address clinical as well as statistical relevance. So that is the overall idea of clinical epidemiology. So the hierarchy of evidence for clinical decision making places the randomized controlled trial or the systematic review as a good quality at the top of the evidence of the pyramid, So the overall strategy which is used in clinical epidemiology is exactly the one which is used in other areas of epidemiology. So observations of events in groups of individuals who share a particular characteristics, and a comparison of the rates of the event among the groups, and then inferring or giving inference regarding the basis for any difference which has been seen in the comparison group is the same as with that of any other types of epidemiology. But in clinical epidemiologic studies, the characteristics that defines the group should be a symptom of a disease or a sign of a disease and an illness. Or the group should be defined by a diagnostic procedure. Or the group should be defined by the treatment given for the symptom or the sign of any condition. So in clinical epidemiology, the characteristics that should be used for defining the group or the comparison group should be based on the signs and the symptoms of an illness, or by the diagnostic procedure, or by the treatment given for the signs and the symptoms of an illness. So the group which is going to be compared in clinical epidemiology will be defined in such a way, So the ways in which the observations in clinical epidemiology are structured are also similar to those of epidemiologic studies intrinsically. That is the ways of just observation. That means the way of data collection. Clinical and general epidemiologic scientific evidence is a prerequisite for providing safe, high-quality patient care and taking maximum advantage of advances in diagnosis, treatment, rehabilitation, and prevention. So clinical epidemiology is aimed to answer the 5 clinical questions. There are 5 clinical questions in clinical epidemiology. So the 5 clinical questions that is going to be answered by this clinical epidemiology is 1, diagnosis. Which examination or which diagnostic procedure should be used to diagnose a disease and to predict its course, or for prediction of the course of the disease, while reducing false positives and false negatives. Results so far as practical, So that in diagnostic research, we are going to just compare which examination methods or tests should be used for diagnosis of a certain health condition and even to predict that health condition, while we are trying to reduce false positives and false negatives. So the first question that is going to be answered by clinical epidemiology is a diagnostic procedure. And the second one is a prognosis. What is the expected course of a disease or a prognosis? Like, for example, spontaneous cure or progression. without clinical intervention, that is during the natural history of the disease, or with the treatment. So what will be the possible outcome or progression of a certain health condition will be just answered by the use of clinical epidemiology. Okay, that's sir. Yeah, actually, knowledge of the natural history of many of the diseases is limited for several reasons, because many have a long asymptomatic phase during which they are unrecognized. As well, most diagnostic or diagnosed diseases and their complications are treated. So we know their clinical course, but not their natural course, because of these two reasons. One, because they do have a long asymptomatic phase, and the second one, most diagnosed diseases are treated, So because of these two reasons, we may not know the natural history of a disease, rather the clinical course of a disease could be just known, And the third question that we are going to answer by using a clinical epidemiology is the etiologic factors for a disease. So this etiology aims to demonstrate or exclude the relationship between a potential cause and the occurrence of a disease or other health outcomes, So that is the third question that we are going to answer by using clinical epidemiology. And the fourth one is intervention, that is intended interventions. There are two types of intervention, unintended intervention and intended intervention. So in the case of intended interventions, to what extent will a specific clinical intervention, whether it is a drug or a vaccine, be beneficial in terms of curing or preventing a disease, or slowing the progression of a disease, or reducing its symptom burden? So that will be the intended intervention question that is going to be answered by clinical epidemiology. But while we are trying to measure the intended intervention, there are also unintended interventions or unintended outcomes. That is the risk, harm, or the side effect. So what are the risks or side effects, unintended adverse effects, or complications of selected treatments and interventions, and the safety and quality of care? So these are the 5 most important questions that is going to be answered by the use of clinical epidemiology. So this is generally the concern of clinical epidemiology. So when we summarize, we'll have just 4 major types of clinical epidemiologic research. The first one is the diagnostic research, the one that we have already said. So the aim of the diagnostic research is to predict the probability of the presence of targeted disease from clinical and non-clinical profile. So the relevance of this diagnostic research is, it is relevant for patient and physician to establish diagnosis and guide management of that health condition. The second one is etiological research. So this is used to know or to causally explain the occurrence of target disease from determinants. So the cause of a certain disease could be just investigated by this etiological research. So this is again relevant for, may indicate means of prevention and causal intervention, If you know the cause of a disease, just there could be an option to prevent that disease, The third one is the prognostic research. That is to predict the course of a disease from clinical and non-clinical profile. And the last one is the intervention research. That is to casually explain the course of disease as influenced by the treatment, or to predict the course of a disease given the treatment. And the clinical and non-clinical profiles will be just investigated. So the first type of research, which is prognostic research, it is aimed to investigation of the relationship between patients' clinical characteristics and future outcomes. That is the prognosis. The future outcomes of a certain health condition will be just investigated. So most patients wish to know the likelihood of being or obtaining relief from symptoms and discomfort, So predicting the course of a disease and trying to improve its prognosis is a key goal of clinical care. So for this reason, clinical epidemiology has an important focus on understanding the prognosis of a certain disease condition. Therefore, in prognostic research, concepts of probability and risk are more important than measurement of relative association, So the probability of getting a certain health condition, or the risk of just developing a certain disease condition, or the risk of days, or the risk of survival could be analyzed by the use of such an approach, So a risk factor is associated with an increased risk of developing a disease or another outcome, while a prognostic factor is associated with an outcome of a disease. So prognostic factor is associated with an outcome of a disease, but risk factor is associated with increased risk of developing the disease. So saying risk factor and prognostic factor are two different things, Risk factor is associated with the risk of developing the disease, but prognostic factor is a factor associated with outcome of a disease. The outcome of the disease could be either days or recovery or maybe complication, as you know. So a factor associated with increased risk of a disease does not necessarily imply poor prognosis once the disease occurs. So a classic example is blood pressure. That means high blood pressure is a risk factor for developing acute myocardial infarction. While low blood pressure after myocardial infarction is a strong prognostic factor for mortality. So saying a risk factor and a prognostic factor are two different things. So after so this is a concern of a prognostic research. And the next one is intervention research. So after diagnosis or after a diagnostic test, application of interventions is a key responsibility of clinicians or physicians. So knowledge of the benefit and risks of interventions provided by clinical epidemiology. That means different interventions could be a drug or a vaccine, which would be produced by or which would be an output of a clinical epidemiology. So knowledge of the benefits and the risks of interventions, which could be provided by a clinical epidemiological research, is central for the decision of the clinicians. So interventions may include either a drug or a surgical procedure or a vaccine or a lifestyle change or maybe a rehabilitation. So human trials are divided into 4 phases based on the objective of the study, as we have seen in the experimental study design. Phase 1, 2, 3, and 4. So this is the concern of interventional research. So phase 1, phase 2, phase 3, and phase 4. I will not say, or I will not take much time over here because we have already seen this phases of intervention studies during the experimental study design session. So the third type of research in clinical epidemiology is the etiologic research. So etiologic epidemiologic research explores the causes of a health outcome. So its aim is to demonstrate or exclude the relationship between a potential cause and the occurrence of a disease or other health outcomes. So to achieve this goal, alternative explanations for an apparent link between determinant and an outcome need to be excluded by using a research, So these alternative explanations are offered by relationships due to extraneous determinants or confounders. So the effect of these confounders should be just explored and controlled to know the specific causative agent for a certain disease. So the form of the etiological occurrence relation, the object of research, is therefore outcome as a function of determinant, conditional on confounders. That means after controlling for the effect of confounders, determinant factors should be investigated for a certain health condition or disease. So that is etiological research. So assessment of confounding by detecting the presence of possible extraneous determinants is critical to obtaining valid results in etiologic studies, So the first step is to clearly decide which determinant is the assumed causal factor of interest for a certain disease. So we need to identify the causative agent of interest for a certain disease. And then for that specific causative agent, we need to collect possible data for all possible confounders in order to control the effect of those confounders. Finally, in order to just prove or disprove that a specific agent is causative agent for a disease or not. So commonly, diseases are caused by multiple factors, which can act in concrete or maybe in separately. So these multiple factors may just act in combination or maybe separately. So in subsequent studies, multiple possible causative agents may be addressed consecutively. Therefore, not only a single factor, but multiple factors or causative agents can be identified by using this etiological research and clinical epidemiology. So at each instant, however, there is typically one determinant of primary etiologic interest. In most of the studies, in clinical research, we will have one primary exposure variable or primary causative agent, and then the others will be taken as secondary causative factors. So we need to identify which one is the primary causal or causative agent and which one are the secondary causative agents for the disease. So confounders can be very specific to a particular determinant outcome relationship. Potential confounders may or may not distort the relationship between the determinant of interest and that of the outcome in a data, depending on the presence or absence of association between these variables. So we have seen that the effect of confounding could be either totally or partially account, or it can hide the true association, or it can change the direction of association, or finally, it may not be a confounder. So the first one is the study of diagnostic and screening tests. That means diagnostic research. That is named as diagnostic and screening research. So that in case of diagnosis or diagnostic or screening tests are done to obtain information that can guide a healthcare provider decision to initiate or to continue a therapeutic intervention. Because after diagnosis or maybe after screening, there could be a treatment or an intervention, So the purpose of diagnosis is just to continue for an intervention. So tests performed in persons with a symptom or sign of an illness are usually said to be diagnosis, whereas those done in healthy individuals without symptoms are said to be screening, as you know. Therefore, accurate diagnosis of a disease is the first step in predicting the prognosis and optimizing the therapy, So clinicians begin the diagnosis process by obtaining a medical, social, and family history, assessing the frequency of potential risk factors, and performing an initial physical examination. Then they make decisions at each step of the process, So finally, diagnosis tests are used to increase the likelihood of determining the presence or absence of a disease and to predict the prognosis finally. So, no diagnosis test is perfect, as you know. There is no diagnostic test which is 100% specific and 100% sensitive. And in clinical medicine, it is common to reduce the results of a diagnostic test to a dichotomous outcome. That means positive for a certain disease and negative for a certain disease. So, the accuracy of a diagnostic test is often said to be evaluated in relation to a gold standard, which would be an ideal diagnostic test with no false positive or with no false negatives. But these types of gold standard diagnostic tests are very expensive and they are not widely available everywhere in the healthcare setup, So with few exceptions, such a test does not exist, A test without false positive, a test without false negative could not exist, since almost all diagnostic procedures require interpretation and they are subject to error. The diagnostic materials are made by human beings, and human beings are not perfect in their activity or in their investigation, And we human beings are subject to introduce error. So because of this, no diagnostic modality could be without false positives and without false negatives. No diagnostic test which is 100% sensitive and 100% specific. So, however, there might be a reference standard which can be a single test or maybe a combination of tests. So the reference standard should be the best existing test among the possible available tests to guide clinical action at the time that a new test is proposed. So if a new test is proposed, so that the validity of the new test will be compared against the gold standard, the one which is the best available. So the sensitivity, that means true positive rate, and the specificity, that means the true negative rate, are classical clinical epidemiological parameters that can be calculated to evaluate the accuracy or the validity of a diagnostic test. So these diagnostic tests will be just the concern of a diagnostic research in clinical epidemiology. So, as you know, diagnosis and screening are the main concerns of clinical epidemiology. So, by definition, screening is application of a test or a procedure to asymptomatic, apparently well individuals in order to separate those with a relatively high probability of having a disease from those with a relatively low probability of having the disease. So that's the definition for screening. Or it is a presumptive identification of unrecognized diseases through tests, examination, or other procedures which can be applied rapidly. So the assumption for a screening program is, because of these two reasons, early detection will lead to more favorable prognosis, a good prognosis. And early intervention, because of early detection, may be more effective than treatment at a later stage of the disease progression. So that is the assumption behind doing screening. And this is early detection will lead to more favorable prognosis during the natural history of the disease. And here is again another graph which shows the natural history of the disease. And we need to be clear about the screening and diagnostic tests. The screening test identifies asymptomatic people who may have a disease. But diagnostic test determines the presence or absence of a disease when patients comes with signs and symptoms. So the aim of doing screening is to reverse or to slow the progression of a disease and to alter the natural course of the disease for a better outcome and to reduce morbidity and mortality through early detection and early treatment and to protect the society from communicable diseases and for rational allocation of resource, for selection of healthy individuals, maybe for military purpose or for employment in a certain occupational setup. And we do also screening for the purpose of research, for the study of the natural history of the disease. So what are the criteria for establishing a screening program? To establish a screening program, one, the condition or the disease should be an important public health problem. The community should be more affected by the disease. So the disease should be an important public health problem, one. The second one is screening should be undertaken only when it has the potential to lead to a significant decrease in the rate of disability or death, or maybe both. And the third one, there should be an accepted treatment for patients who will be diagnosed with the disease. We'll do screening if there is an existing treatment for that specific disease. And the fourth one, there should be facility for diagnosis and treatment, you know. Facilities for diagnosis and facilities for treatment should be available. Unless and otherwise there is a diagnosis and treatment, what is the purpose of screening? After screening, if a patient is suspected to have a Z disease, but if no treatment is there, what will be the purpose of doing screening? So there should be a diagnostic and treatment facilities to do a screening program. And the fifth one, there should be a recognized latent or early symptomatic stage. The disease should have a latent or longer incubation period, you know. Otherwise, if the disease does not have a latent stage, there is no option to detect the disease through screening. And the sixth one, there should be a suitable test or examination which has high validity. That means there should be a suitable test or a suitable screening modality or procedure which has high validity, and that the validity of the test will be measured by the sensitivity and specificity. To say the test is highly valid, it should have high sensitivity and high specificity. And the seventh one, the test should be acceptable to the population. If the community does not accept the test, then we will not be in a position to do a screening, you know. So the test should be acceptable by the population. And the eighth one is a suitable screening test or procedure should be available, and that test should be reliable or replicable. When you do repeatedly or when you screen an individual repeatedly with that screening test, the same result should be produced. It should bring the same result when it is done repeated number of times. So the screening test should be reliable, it should be sensitive and specific, it should be acceptable to the population being screened, and it should be reasonably inexpensive and safe. So these are the criteria behind establishing a screening program. So now let's proceed to see the validity or the accuracy of a diagnostic or maybe a screening test. Okay, so the validity of a test is the ability to differentiate accurately between those individuals who have the disease from those individuals who do not have the disease. So the ability of the test correctly identifying those individuals with the disease from those individuals without the disease is said to be the validity. So sensitivity and specificity are the two measures of validity of a screening test. So validity of a test is the ability of the test to correctly identify those individuals having the disease from those individuals without the disease. So the validity of the test will be measured by the sensitivity and the specificity of the test. So now let's have a look at on this graph to just make clear between the difference between accuracy, that is validity, and precision or reliability. For example, in the first graph, in the first circle over here, the true value is at the center over here, at the center. But these are the different measurements which were made repeatedly, you know. So the closeness of the measured value to the true value is said to be validity or accuracy. As you can see over here, the measured values over here, they are not close to the true value, that is to the center. So we say there is low accuracy because the measured values are not close to the true value. There is low accuracy, but they are highly precise or reliable. Reliability is the closeness of different measurements towards each other. These measurements, these 5 measurements are close to each other, so they are reliable or there is high precision. In the second circle, the measured values are closer to the true value, that is to the value to the center. So there is high accuracy. but these measurements are not close to each other. They are far apart from one another. So there is low precision. And the last circle over here, the measured values are close to each other and they are close to the truth value. So there is high precision and high accuracy. So that is the difference between reliability and validity. Reliability or precision, validity or accuracy. So accuracy or validity is the closeness of the measured value to the true value. But reliability is the closeness of different measurements towards each other. So how do we judge the validity of a test? Validity, that is the closeness of the measured value to the truth value. How do we measure the validity of the test? By the use of sensitivity and specificity. As you can see from here, the table, maybe you are familiar with this from your basic epidemiology. We'll have a gold standard test which could identify correctly those individuals with the disease and without the disease. And there will be a screening test which would say positive and negative. So there will be true positives, false negative, and true negative. So as you know, sensitivity is the ability of the test to identify correctly those individuals who have the disease. So that means in this case, the sensitivity of the screening test will be true positive over the true positive plus false negative. This one. And specificity is the ability of the test to correctly identify those individuals without the disease. That means true negative divided by true negative plus false positive. This one. So that is sensitivity and specificity, and actually by now you are clear with that. So sensitivity minimizes false negatives if the test is highly sensitive. If the test is highly sensitive, false negatives will be minimized, but false positives will be increased, Highly sensitive test will minimize false negatives, but it will increase false positives. Sensitive test with negative result rules out a disease. If the test is highly sensitive, for a highly sensitive test, if the test result is negative, definitely the individual is free from the disease. So sensitivity is calculated by true positives over true positive plus false negatives, as I have said before. And the specificity is the ability of the test to correctly identify those individuals without the disease. So if the test is highly specific, it minimizes false positives. A test with high specificity will have low false positives, but it will have high false negatives, false negatives to the opposite. So a high specific test, if it does have a positive result, definitely the individual has the disease. If an individual is positive with a highly specific test, definitely the individual has the disease. So specificity is calculated by this formula, true negatives over true negative plus false positives. The false positives are, in reality, they are negatives, Another issue in screening is a positive predictive value and negative predictive value. So positive predictive value is the percent of positive tests that are truly positive. Among those individuals who had been positive by the test, how much percent of them are really positive? That is positive predictive value. So if test result is positive, what is the probability that the patient has the disease? That is the idea of positive predictive value. So positive predictive value is affected by several factors, including the specificity of the screening test and the prevalence of the disease. When the prevalence of the disease increases, the positive predictive value increases. When the prevalence decreases, the positive predictive value also decreases. Okay. Another issue is negative predictive value. That means the percentage of negative tests that are truly negative. If the test result is negative, what is the probability that the patient does not have the disease? Among those individuals who had been said negative by the test, how much of them are really negative? That is the idea of negative predictive value. So a high sensitivity test will have low false negatives. So if the false negatives are low, so the predictive value negative will be high because false negatives are low. And if the test is highly specific, there will be low false positives. If the false positives are low, then the positive predictive value will be high. So sensitivity and specificity are constant for a particular test, But the positive predictive value and negative predictive value vary dramatically, depending on the prevalence of the disease, depending on the sensitivity and specificity of the test. So low prevalence, low positive predictive value, but high negative predictive value. High prevalence, high positive predictive value, but low negative predictive value will be. Here is a graphical presentation. As the prevalence increases from here to here, the positive predictive value, this line, will be increasing, but the negative predictive value will be decreasing, So how do we calculate the positive predictive value and the negative predictive value? So actually, this is the way how we can calculate the sensitivity, true positive over true positive plus false negative, and specificity, true negative over true negative plus false positives. So the positive predictive value will be calculated by using this formula. The true positives over true positive plus false positive. Among the total individuals who had been positive, who has been said positive, how much of them were positive really? So positive predictive value will be calculated by this formula. True positive over true positive plus false positive. And negative predictive value will be calculated by the second formula. The true negatives over true negative plus false negative. Among the total number of individuals who had been said negative, how much of them were really negative? That is negative predictive value. So let's have just some additional example when the prevalence of a disease increases and decreases, When the prevalence of the disease is, for example, is 1.5. Now, if you calculate with this, the given numbers, the sensitivity will be 95, the specificity will be 90%. There will be a gold standard test for the HIV test, and the screening test is a LISA test. So, the total number of positives, 14 plus 1, 15. If you divide 15 for the total population, this 15 over 15 plus 985, that means 1,000. 15 by 1,000, so the prevalence will be 1.5. So when the prevalence is 1.5, if you calculate the positive predictive value, the true positives over true positive plus false positive, that is around 12.4. And the negative predictive value is now 99.9. Okay, now mind you that the prevalence is 1.5. Okay, so now let's proceed to the next slide. Now the prevalence of HIV is increased to be 6%. But sensitivity and specificity are still the same, remains the same. They are fixed, They will not be changed based on the prevalence of the disease. But the positive predictive value is now 37.75, which is much larger than the previous one. Previously, it was 12.4% over here. But now when the prevalence increases to 6%, the positive predictive value dramatically gets rise to 38%. And the negative predictive value have a slight reduction, 99.6. Previously it was 99.9, but now it is 99.6. So as the prevalence of a disease increases, the positive predictive value increases, but the negative predictive value will decrease. And again, when the prevalence of a disease gets raised again to 24%, sensitivity and specificity remains the same. Positive predictive value becomes now 75, and negative predictive value reduced to 98.3. So this is an illustration of how the positive predictive value and negative predictive value will be changed based on the prevalence of the disease. So now, as we have said before, sensitivity and specificity of a screening test are fixed, they are constant. But we can change the sensitivity and the specificity of the test by changing the cutoff levels of the test, the threshold level. When disease is defined by a threshold on a continuous test, the test characteristics can be altered by changing the threshold or cutoff point. So lowering the threshold improves the sensitivity, but often at the price of lowered specificity. That means more false positives will be there. For example, lowering the threshold improves sensitivity means if a clinician diagnosed a patient with TB, to diagnose a patient to be positive for TB, a clinician may consider from the signs and symptoms, for example, cough of more than 2 weeks duration, okay, weight loss, okay, night sweating, loss of appetite, okay, again a sputum smear positive result, and suggestive X-ray finding. I have listed at least 6 criteria. Okay, now there are 6 criteria to be for a patient to be positive for tuberculosis. But if we minimize some of the criteria, for example, if a physician simply relies on cough of duration of 2 weeks and above to say a patient is positive for TB, easily the patient will be diagnosed as TB positive, excluding sputum smear positive, suggestive X-ray finding, night sweating, loss of appetite, weight loss, whatever. Only relying on the cough with 2 weeks and more than, cough of 2 weeks and more than 2 weeks. If we rely on a single criteria, we are increasing the sensitivity. That means we easily identify or diagnose individuals to be positive for a disease. With this single criteria, most of the individuals will be labeled as false positives. So the false positives will be increased, So that is lowering the threshold will increase the sensitivity, but at the cost of lowered specificity. We will not say an individual negative for TB, The specificity will be lowered if you increase the sensitivity. As I have said before, if you rely on simply a cough of duration of 2 weeks and above to say TB positive, individual will not be said negative for TB. Easily he will be positive. So lower the specificity. False positives will be increased. Okay, to the opposite, if we raise the threshold, raising the threshold improves the specificity. If we add number of criteria for an individual to be positive for a certain disease, he should fulfill all those criteria. So we will not easily say positive for that disease, so that the patient will be more likely to be negative for the disease when we increase the criteria, when we raise the threshold. For example, to diagnose a patient as a DM or diabetic patient, the normal range might be 70 to that of 120. Okay, now, rather than saying a DM at a cutoff level of 120, if you say 200, the patient will not be easily positive for DM if the cutoff level is at 200 level, So that raising the threshold will improve the specificity. We will say easily negative for the disease, but at the price of lowering sensitivity. most of the individuals will not be found to be positive. So an individual with the disease will be falsely negative, will be labeled as falsely negative. So when we increase the threshold, false negatives will be increased because the specificity is increased. So this is a way how to just change the sensitivity and the specificity. But there are conditions to increase or decrease the sensitivity or the specificity of the test. What are the conditions to change the trade-off or the threshold level? Okay. Let's have a look at over here. We will increase the sensitivity. That means we will lower the threshold. To increase the sensitivity, the threshold should be lowered, you know. So we will increase the sensitivity if the disease is serious and definitive treatment exists. If the disease is serious, it is better to say falsely positive and treat the patient even though the individual does not have the disease. Rather than missing the individual with a serious disease, it is better to just treat an individual without the disease. Even though, because when we increase the sensitivity, there will be more false positives. So when the disease is serious and definitive treatment exists, we will increase the sensitivity. When the disease is again highly communicable, when subsequent evaluation of positives is not costly and has minimal risk. So with these conditions, sensitivity will be increased. Okay, to the opposite direction, we will increase the specificity when high risk with further diagnosis is there for the individual. When further diagnosis is having a high risk for the individual, and again when high cost is there with further diagnostic test, procedure, and when there is no definitive treatment. That means if there is high risk for further diagnosis, if there is high cost for further diagnosis, and if there is no treatment for after diagnosis. So what is the purpose of knowing the patient status? It is better to say the individual, you are free from the disease and you can go to your home. Because there is no definitive treatment. And in addition to that, there is high risk for further diagnosis and there is high cost for further diagnosis. So by increasing the specificity of the test, we simply will just let the patient to go to his home by telling he is free from the disease. So these are the conditions to just increase the sensitivity and the specificity of a test.